Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer reviewed and free.
Hello and welcome to the Australian Prescriber Podcast. My name's Jo Chia and joining me today is George Mangos, who is a nephrologist at St George Hospital and an associate professor of medicine at UNSW. Hi George, thanks for joining me.
Hi Jo, and thanks for having me. It's a pleasure.
That's great. So happy to have you. So your article in the Australian Prescriber is about hypertension in pregnancy. So physiologically, how does pregnancy affect blood pressure? For example, why does blood pressure drop in the first trimester of pregnancy?
Okay, good question to start the talk because we're talking about high blood pressure. And yes, the normal response to pregnancy is vasodilation and therefore a lower peripheral resistance. And that's the primary driver of the fall in blood pressure, which generally starts at about 8 weeks gestation. And that's despite the other changes that occur during the pregnancy, which is an increase in cardiac output and an increase in circulating volume.
And in terms of throughout the rest of the pregnancy, how does the blood pressure change?
So the fall in blood pressure that occurs in the first trimester is generally maintained and reaches its lowest point in the second trimester. In the third trimester, we start to see blood pressure increase in a normal pregnancy back towards the baseline blood pressure at booking. And that would generally occur at about 34 to 36 weeks. And then at term, generally the blood pressure is as it was in a non-pregnant state.
And you've written this article about managing hypertension in pregnancy. So obviously, some things might go a bit wrong or things might not be as they should be. So can you explain the different types of hypertensive disorders in pregnancy?
Yeah, of course. A woman can be diagnosed with high blood pressure or hypertension before she falls pregnant. So that's referred to as chronic hypertension. And we would call chronic hypertension an elevated blood pressure that's measured before 20 weeks gestation, because some of these women have never had their blood pressure measured before. So if the blood pressure is elevated before 20 weeks gestation and it's sustained and confirmed, that's consistent with chronic hypertension. For the other hypertensive disorders, they tend to occur after 20 weeks gestation, and those disorders include gestational hypertension and preeclampsia. And then, of course, if a woman has chronic hypertension, it can be complicated by preeclampsia, which is a systemic condition affecting multiple organs in the body. So that form of hypertension is called preeclampsia, superimposed on chronic hypertension. With chronic hypertension, it's divided into two main categories, primary and secondary. Now, often chronic hypertension is so-called primary or essential hypertension. And then there are other causes of chronic hypertension, such as kidney disease, adrenal disease, renal artery stenosis, polycystic kidney disease, for example. And often in pregnancy, it gives us the opportunity to diagnose these conditions because, as I said, maybe the first time that a woman has had a blood pressure carefully measured and even perhaps a measurement of urinalysis.
And I guess preeclampsia is the scary term for a lot of people. Can you explain the importance of the condition and what it actually means for the pregnant woman?
So, preeclampsia is a condition where the placenta probably releases factors into the blood that affect the mother. The interaction between the placenta and the uterus is probably not normal from early in pregnancy. So, as a complication of that, this condition called preeclampsia develops, which is often characterized by swelling of the legs, which comes on quite suddenly, protein appearing in the urine, which can be detected by a dipstick when it's tested, and an increase in blood pressure, amongst other symptoms. It usually occurs either at term or very close to term after 36 weeks gestation, but can occur earlier. And one of the main reasons women have antenatal care is to look for this condition developing, to make sure that baby is growing well, to make sure that blood pressure remains normal, that there's no protein in the urine, that there are no symptoms of preeclampsia, for example. It's scary because it sounds pretty nasty and it can become a serious condition. And in Australia, under good surveillance, our outcomes are very good and mothers and babies do very well. But yes, it can be a serious problem, particularly in countries where we don't have excellent antenatal care.
In terms of the other hypertensive disorders you just mentioned, how do you manage each of those?
In pregnancy, when we diagnose chronic hypertension, which is a blood pressure above 140/90 that's confirmed after a few readings or after 24-hour blood pressure monitoring. So when we diagnose that, it doesn't really matter whether it's primary or secondary or what's causing it. The important thing is that the blood pressure is controlled and that the kidneys and liver and other organs in the body are essentially functioning normally. Management of the various different conditions that cause chronic hypertension. For example, if a woman has kidney disease, we keep a close eye on her kidney function. If the hypertension is due to a more rare condition, such as an adrenal problem, we might need to use slightly different medication. But essentially, the principle is to keep the blood pressure under control, because we know that if blood pressure is uncontrolled at the beginning of pregnancy, then the outcomes at the end of pregnancy are more complicated. And certainly, it's less safe on mum and less safe on the baby if blood pressure is not controlled well in early pregnancy. One thing we can do for women who enter the pregnancy with chronic hypertension is to try to reduce the chance of it developing into a more complicated situation of preeclampsia by using two treatments. One of them is low-dose aspirin and the other is calcium supplementation. So low-dose aspirin is commenced between 12 and 16 weeks gestation, usually at a dose of 150 milligrams daily. And although aspirin, when you read the label, it says it's not safe in pregnancy, that's when higher doses are used in the anti-inflammatory dosing. But with low-dose aspirin, with a more antiplatelet type dosing, we've seen studies that have clearly shown a benefit in protecting women from early onset preeclampsia if they enter the pregnancy at a higher risk. And that's why it's so important to get these women with chronic hypertension or indeed other high-risk situations onto aspirin between 12 and 16 weeks gestation. Calcium supplementation hasn't been proven as well as aspirin has, but it's clear that women who have calcium deficient diets have a higher rate of developing preeclampsia. And because calcium is such a safe mineral to take and an important mineral to take, we like to be sure that women have an adequate calcium intake, and often it's easier to use some extra calcium carbonate rather than take a lot more dairy product. So they're the two things that we can do to help lower the risk of chronic hypertension becoming more complicated, along with controlling the blood pressure with safe antihypertensive medication.
It's very interesting to know that outcomes can be improved if hypertension is picked up and we intervene earlier in the pregnancy than later. And you've just mentioned some safe antihypertensive drugs. So in your article, there are some really good tables that our listeners and readers can refer to. But what are some of the antihypertensive drugs that are safe to use during pregnancies, and which ones should be avoided?
Probably the one drug that has the highest pregnancy category listing is methyl-dopa, and that's because it's probably the oldest and has been involved in a randomized controlled trial in the past. Most of the other drugs we use are either category B or C. So methyl-dopa is widely used. It's a centrally acting drug. It does tend to cause a bit of tiredness in women and some other symptoms, but it is widely used and safe, and certainly safe for the fetus. The other class of drug that we would use first line or second line would be a beta blocker, currently using labetalol, and often use that 100 milligrams twice to three times a day as a starting dose, increasing to 200 or 300 milligrams three times a day. Labetalol has both beta blocker and alpha blocker activity, and again, another safe drug for mother and fetus. Nifedipine and other calcium channel blockers are increasingly used first and second line. We know they're safe. Again, they don't affect the fetus. They do tend to cause side effects. We know about the side effects of peripheral calcium channel blockers being flushing and tachycardia and leg swelling. And in a situation like pregnancy where vasodilation is already the state, then it's not unusual to see these symptoms occur in women. And there are other agents we use second, third, fourth line, such as hydralazine and prazosin, and they're also safe in pregnancy. So first line could be methyl-dopa, nifedipine, labetalol, combination of any of those three. And they're the drugs that we would generally be trying to stick to in pregnancy, including the first trimester if necessary. And indeed, even antepartum, preparing a woman during her preconception counselling and preparation for pregnancy to take at that time if we're already seeing the patient.
That's also interesting that you can start treatment in the preconception period as well. So, we've spoken about some medications, we've also spoken about some preventative therapies like aspirin and calcium. So, what are some non pharmacological methods of preventing or managing hypertension in pregnancy?
Actually, there aren't any non-pharmacological measures that have been proven to improve maternal or fetal outcomes in this situation. But it makes sense for a woman, for any pregnant woman really, not to gain too much weight, to have a healthy, balanced diet, and not necessarily to restrict or take any component of their diet in excess. For example, in patients who are not pregnant, there's evidence that lowering dietary sodium can lower blood pressure. We don't recommend that in pregnancy because a pregnant woman requires salt to maintain an expanded plasma volume and tends to have a salt craving. And there's been no evidence to show that lowering salt intake is a benefit to a pregnant woman. So there are certain things that we can do outside of pregnancy that we don't recommend in pregnancy. So just a healthy, balanced diet. Physical activity obviously is appropriate and recommended for many reasons, not just the metabolic benefits to reduce an excessive gain in weight, but also the mental health benefits. And potentially, physical activity may have a benefit on lowering the inflammatory status inside a patient. And we don't know, but it's possible that regular, gentle physical activity may have a beneficial effect on lowering the rate of preeclampsia, but that's not yet proven.
And are there current studies that are looking at proving or disproving these methods?
Yeah, look, I think the real goal here is to find something that prevents preeclampsia. And aspirin does it to a very limited degree, generally in women at high risk and generally for preventing early onset preeclampsia. What we really like to do is prevent preeclampsia occurring in any woman. To do that, firstly, we need to know which woman is going to get preeclampsia. So we need a test at the beginning of pregnancy that says, okay, you're going to get preeclampsia or you're at very high risk of getting preeclampsia. And we're starting to get tests that show that. And then we'd need a treatment that we can implement that changes the outcome of the pregnancy. And as I said, we've got aspirin and calcium now. Drugs are being tested in Australia actually to look to see whether they can have an impact on the rate of preeclampsia developing. People have looked at all sorts of other complementary agents in the past, and unfortunately, they don't work. So there's a whole lot of supplements that have been tested, such as vitamin C and antioxidants, and none of them seem to work. So we know what works a bit and we know what doesn't work. And there's a lot of potential in the future for pharmacological and non pharmacological agents to work, but we don't have any further answers yet.
It's very interesting to hear that there are some diagnostic tools or maybe criteria that patients may meet early in pregnancy that can preempt whether they will experience preeclampsia. So, what do those sorts of tools look like?
I suppose we could group that into clinical assessment. So if we see women who have certain risk factors, and there are a number of risk factors for preeclampsia, and that might include chronic hypertension as one, but being overweight, the traditional cardiovascular risk factors such as dyslipidemia and diabetes, having an IVF pregnancy, a woman in her first pregnancy, a twin pregnancy, they're risk factors for going on to develop preeclampsia. So we can make that assessment clinically. We now also have, and of course, a woman who's previously had preeclampsia. So if a woman's in her second pregnancy and she didn't have preeclampsia in her first pregnancy, then her chance of getting it in her second pregnancy is very low. It's around 1%. Whereas if a woman's had preeclampsia in the first pregnancy and comes into a second pregnancy, she's at much higher risk. And that could be 15 to 25 or even 35, 40% risk of getting preeclampsia in the second pregnancy. So those clinical aspects we can assess in the rooms. Then there's tests, and what's become more sophisticated is the early ultrasound at around 14 weeks gestation, where a number of parameters are measured, including blood pressure and some placental hormones and a Doppler measurement of uterine artery waveform. And a combination of these in an algorithm can give a prediction as to whether a woman is at high or low risk of early onset preeclampsia. And we see now women having this test done and turning up with a report that says this woman is at increased risk of early onset preeclampsia. We recommend low dose aspirin. And often that's followed through even before the obstetric medicine team becomes involved. And because low-dose aspirin is such a safe drug, it's good for that to happen in a way. It does mean that some women will be treated who won't end up getting preeclampsia anyway, so the number needed to treat might be relatively high, but because it's a safe drug, it's quite reasonable to take that approach. The algorithms that are being used to predict preeclampsia and to put women onto aspirin early are improving over time, and I'm sure with better Doppler measurements, all of these measurements and calculations will improve over the next few years.
And I guess if a woman was ticking off some of those high risk criteria that you've just been discussing, for example, they start the low dose aspirin, is it recommended that they're referred to a particular specialist, or can they continue their treatment under, for example, their GP or other clinicians?
Yeah, it all depends on the antenatal model that the woman is booked into. And increasingly, GPs are becoming more involved with the higher risk pregnancies. So, I guess what's more important than referral to a particular specialist is to categorize that woman as a high risk pregnancy or not a high risk pregnancy. And once that woman is considered to have a high risk pregnancy because of either the early ultrasound and blood tests or her clinical status, then the antenatal surveillance is perhaps a little bit closer, a little bit more vigilant. And particularly in the third trimester, she may be attending her hospital where she's booked in a lot more regularly. We do that at St George Hospital and many other hospitals around Australia in units like a day assessment unit, where instead of just staying for a few minutes and having a blood pressure check and coming and going, she might stay for 3 or 4 hours, have blood tests, have a CTG to look at both maternal and fetal welfare and careful measurements of blood pressure over time. So that's more likely for women who are at high risk who need to be monitored a bit closer.
So that brings us to the end of the episode, George. Thank you so much for joining us on the podcast.
It's an absolute pleasure. Thank you very much. And may I thank and acknowledge my co-author, Dr. Amanda Beach, who's an endocrinologist and obstetric physician at the Royal Hospital for Women in Sydney.
Thank you, George and Amanda, for the article, and that full article is available online. My name's Jo Chia. Thanks for joining us on the Australian Prescriber Podcast.
Welcome to the Australian Prescriber Podcast. Australian Prescriber, independent, peer reviewed, and free.
The views of the hosts and the guests on the podcast are their own and may not represent Australian Prescriber or NPS Medicine Wise.